So let's start talking about nerve injuries. So we'll start with the easiest one, axillary nerve injury. So what we want to know as we think through all of these nerve injuries, we want to know what will be the clinical manifestation, what will be the functional losses that the patient will present with. In other words, how would you test for that nerve injury? And the other thing we want to know is, what are the most common methods of injuring the nerve? Where do these nerves get injured and how do they get injured? So for the axillary nerve, we said the most important thing it does is it innervates the deltoid, and the deltoid is the major abductor. And so therefore an axillary nerve injury will lead to a loss of abduction at the glenohumeral joint. Okay, so that would be the major finding. The way the axillary nerve gets injured is usually one of two ways, either as a result of a fracture of the surgical neck. The surgical neck is the very upper end of the shaft of the humerus, and the axillary nerve, as it leaves the axilla, lies right up against the surgical neck. And we'll see a picture of that later on when we take a look at the shoulder. We'll see how the axillary nerve sits right next to the surgical neck and see how it could get injured. The other mechanism for injuring the axillary nerve is a shoulder dislocation, glenohumeral joint dislocation. And again, when we take a look at a picture of the shoulder region, we'll see the relationship between the shoulder joint and the axillary nerve, and we'll see why it can get injured in shoulder dislocation. So those are the two major mechanisms. Keep in mind that the axillary nerve is the only nerve that's likely to be injured with a surgical neck fracture. So if you're presented with a patient with a surgical neck fracture of the humerus, think axillary nerve. On the other hand, shoulder dislocation, axillary nerve is going to be one of two nerves that can get injured. We'll talk about the other one shortly. So you can't automatically assume that it will be axillary nerve if there's a nerve injury associated with a shoulder dislocation, but it's one of the nerves that might be injured. So that takes care of the axillary nerve. We can dispense with the musculocutaneous nerve pretty quickly for two reasons. One is it very rarely gets injured. It doesn't run in a position that it's subject to many injuries. It stays at a fairly safe location, so it's hard to injure it. And number two, we already know what it does. It just innervates anterior arm muscles. So if you did injure it, you're going to have a loss in elbow flexion. So that's the major thing, but not a very high yield topic. So let's just continue on. The radial nerve, on the other hand, is a very important nerve with regard to nerve injuries because it is a very frequently injured nerve, One of the reasons it's injured so frequently is because it has a very long course. Nerves that have very long courses will get injured more frequently than nerves with short courses, right? The longer its course, the more places it can get hurt. So long nerves get injured more than short nerves. Radial nerve is a very long nerve. And the other reason is that the radial nerve happens to run through some territories, through some regions that are pretty dangerous, where it's easy to injure it. So radial nerve injuries are very common. Now, when you have a nerve like the radial nerve that has a long course, innervates lots of things along the way. Remember, the radial nerve does all of the posterior arm muscles, all of the posterior forearm muscles. It's also responsible for cutaneous sensation on the back of the hand. So it innervates a lot of things along the way. In thinking about an injury to that nerve, in addition to knowing what the nerve innervates, you also have to pay attention to where the nerve is injured. Because only those structures that are distal to the site of the injury will be affected by the injury. In other words, if you were to injure the radial nerve, let's say in the forearm, anything that the radial nerve innervates up in the more proximal arm will not be affected by that injury. So only structures innervated distal to the injury would be affected. That means that if you wanted to do one functional test, one motor test on a patient to rule in or rule out a radial nerve injury, the smart thing to do would be to test a distal function. because a distal function would be affected by a nerve injury regardless of whether the injury was a proximal or a distal injury. In contrast, a proximal function would only be affected by a proximal injury. It wouldn't be affected by a distal injury. So you'd want to test a distal function as your initial screening test. And the most distal function of the upper limb that is a pure radial nerve function is wrist extension. Wrist extension. So the initial screening test for a radial nerve injury is to test the patient's wrist extension. So you just ask the patient to hold their hands out in front of them, palm facing down, hold their hands out in front of them, and they need to use their extensor muscles to resist gravity. If their radial nerve is injured, then their extensor muscles are weakened and they can't resist gravity, and they will have what's called a wrist drop. Wrist drop. Gravity will pull the hand down, resulting in a wrist drop. So if you see the phrase wrist drop in a question, you immediately know that this patient has a radial nerve injury. You don't yet know where the radial nerve is injured, but you know it's a radial nerve injury. And it's almost certain that in the presentation of the patient, in that vignette, they would include wrist drop as one of the findings because it's the first test that you would do. So it would be presented as part of the finding. Okay, so now let's think about what happens if the radial nerve is injured at different levels. Let's start with the most proximal level, which would be at the axilla, where the radial nerve first starts. When it comes off the posterior cord, we're still up in the axilla. So if you injure the radial nerve in the axilla, you will have injured the nerve before it has innervated anything. So all of the distribution of the radial nerve would be affected. Posterior arm muscles, posterior forearm muscles, cutaneous on the back of the hand. So you'd have a loss of elbow extension, a loss of wrist extension, loss of finger extension, right? We said wrist drop. And because it innervates the skin on the back of the hand, you'd have a loss of sensation on the posterior hand. Okay, so that's pretty much the entire distribution of the radial nerve. The way the radial nerve can get injured in the axilla is one of two ways. One is a shoulder dislocation. Remember when we said the axillary nerve can be injured by a shoulder dislocation? We said there was another nerve that could be also. Well, radial is the other nerve. So radial nerve can get injured by shoulder dislocation. And the other method is upward pressure in the floor of the axilla, something pushing up into the floor of the axilla. Sometimes that's described as a crutch injury, where the patient was supporting their body weight on a crutch. And if you don't use the crutch correctly, the correct use is just to support your weight on your hand. But if the patient is supporting their weight on the top of the crutch, on their armpit, on their axilla, then the crutch is basically pushing up into the floor of the axilla. And when that happens, you're going to push the radial nerve right up against the humerus and compress the nerve. Another way that sometimes is described is what leads to what's called Saturday night palsy, where the patient was sitting on a high back chair, like a bar stool, for example, with their arms over the back of the chair. And so if they're sitting at a bar and drinking too much and fall asleep in that position with the arm over the back of the chair, you're basically, again, supporting your body weight on your axilla, and you can compress the radial nerve. And it got the name Saturday night palsy because there was a time when most people did their drinking on Saturday night. And so sitting on a bar stool and falling asleep was something that would happen on Saturday nights, and so it got to be called Saturday night palsy. Okay, so that's a proximal injury of the radial nerve. If we go out a little more distal, after the radial nerve has left the axilla and entered the arm, as the radial nerve runs through the arm, it lies right up against the middle two-thirds of the shaft of the humerus, what's called the mid-shaft of the humerus. There's a groove in the humerus called the spiral groove, or the muscular spiral groove. It spirals around the mid-shaft of the humerus. The radial nerve sits in that groove. So for about two-thirds, the middle two-thirds of the length of the humerus, the radial nerve is right up against the shaft of the humerus, And therefore, if you fracture that shaft anywhere in that region, you're endangering the radial nerve. Now, this is more distal than the previous injury, so by the time the nerve has gotten that far out into the arm, it has already innervated most of the triceps. So the triceps is pretty much spared with this injury. So the patient does not lose elbow extension. But you have now knocked out the posterior forearm muscles, and so you do have a loss of wrist extension and digit extension, so you still have the wrist drop. And you still have that sensory loss on the back of the hand. Okay? But you don't have a loss of the triceps, so you don't have a loss of elbow extension. So what we're seeing here is the injury is a little more distal, so there are somewhat fewer clinical findings. If we go further distal to where the radial nerve has now crossed the elbow, okay, oops, we've gone too far. Let me back up a second. To the region of the elbow. As right after the radial nerve crosses the elbow, it's sitting right up against the head and neck of the radius. It's right up against the head and neck of the radius. So a radial head injury, radial head fracture, or a radial head dislocation can injure the radial nerve at that level. Well, when we've gotten that far out, not only have we already innervated the triceps, but we've already innervated some of the more proximal forearm muscles, because some of the forearm muscles actually start in the distal arm and get innervated before they cross the elbow. And so some of the forearm muscles are spared, some of them are not. And so rather than having a loss of wrist extension and digit extension, we're going to have a weakness of extension, because you lose some extensors, but not all of them. So you'll have a weakness of extension, but you'll still have that same sensory loss on the back of the hand. And now if we go out further distal to the level of the wrist, when the radial nerve crosses the dorsum of the wrist to enter the hand, it really is not the radial nerve anymore. At that point, it's just the superficial branch of the radial nerve. Because remember, the only function the radial nerve has on the hand is cutaneous sensory innervation. There are no muscles for it to innervate on the posterior hand. So the branch that goes into the dorsum of the hand is the superficial branch of the radial nerve. And because it is superficial, it can be easily injured as it crosses on the dorsum of the wrist by a fairly superficial laceration on the dorsum of the wrist, or, again, because it's superficial, it's not very hard to compress it. Injure it with compression, like if you're wearing a watch band that's too tight, you can compress that nerve. Okay? With an injury to that nerve, again, remember, you'll have no muscle weakness at all because there are no muscles distal to the injury innervated by the nerve, but you will have that sensory loss on the dorsum of the hand. Okay? So we see the pattern of the more distal the injury, the fewer and fewer will be the clinical findings. So that takes care of the radial nerve. Let's now go on and do the median nerve. So the median nerve, again, is a nerve that innervates a bunch of things, has a fairly long course. It innervates almost all of the anterior forearm muscles and several of the hand muscles. The median nerve can get injured commonly at two locations. The most common place for injuring the median nerve is as it crosses the wrist, so we'll do that first. And then less common is as it crosses the elbow. So let's talk about injuring it at the level of the wrist. There are two common ways of injuring it at the wrist. By far the most common median nerve injury is by compression of the nerve in the carpal tunnel compression. Remember that the median nerve is the only nerve that goes through the carpal tunnel. It's the median nerve plus 9 tendons that are in the tunnel, so the median nerve can get compressed. That's the most common cause of median nerve injury. Another cause of injury at the level of the wrist is a wrist laceration proximal to the carpal tunnel. Before the median nerve enters the carpal tunnel, it's actually quite superficial at the very distal forearm, and so a superficial laceration on the ventral side of the wrist can injure the median nerve. Remember, we said a superficial laceration on the dorsum of the wrist can injure the superficial branch of the radial nerve. On the ventral side of the wrist, it's the median nerve that's in danger. But in both cases, recognize that you're injuring the nerve at the level of the wrist, so that means that the muscles in the forearm that are innervated by the median nerve would not be affected because they're proximal to the injury. So only muscles that are in the hand would be affected. So let's talk about the muscles that are in the hand that are median nerve muscles. Remember, we said that those are the 5 exceptions. We said they were the 3 thenar muscles at the base of the thumb and the first and second lumbrical muscles. So let's talk about the muscles at the base of the thumb. Those muscles collectively are called the thenar muscles, and they cause the bulge that we see at the base of the thumb. That bulge is called the thenar eminence. The bulge is caused by the presence of the muscles. So that means that if those muscles are chronically denervated, those muscles will atrophy. Right? If you denervate a muscle and it stays denervated over a long period of time, the muscle atrophies. And so if the thenar eminence is being caused by those muscles, then atrophy of those muscles would result in a flattening of the thenar eminence, a flattening of the thenar eminence. So if you see that phrase in a question, flattening of the thenar eminence, that tells you it's a median nerve injury. Or they could show you a picture of a patient's hand, and if you see both hands and can compare one side to the other, you'd recognize a flattening of the thenar eminence. It tells you it's a median nerve injury. But let's think about the functional losses associated with denervation of those muscles. Before we do that, let me just point out to you that flattening of the thenar eminence will only occur with atrophy of the muscle, which means it only occurs with chronic denervation. So something like carpal tunnel compression will lead to that. An acute injury, a laceration of the wrist, will not result in flattening because those muscles will not atrophy immediately. It would take a long time. So you won't see flattening. You'll see paralysis, but you won't see a flattening because the atrophy hasn't happened yet. All right, let's talk about functional loss. So those 3 thenar muscles are called the flexor pollicis brevis, the abductor pollicis brevis, and the opponens pollicis. Flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis. So if you paralyze the flexor pollicis brevis, the question is, can you still flex your thumb? And the answer is, yes, you can. Because there's another muscle called the flexor pollicis longus that you haven't paralyzed. Remember, the reason this is called flexor pollicis brevis is because there's another one called longus. So the flexor pollicis longus actually comes from the forearm, so it's still innervated if you injure the median nerve of the wrist. So you can still flex your thumb. If you paralyze the abductor pollicis brevis, you can abduct your thumb because you still have an abductor pollicis longus. Again, it's called brevis because there's another one called longus, which also comes from the forearm. It's actually innervated by the radial nerve. So you can still abduct your thumb. But if you paralyze the opponens pollicis, recognize that's not called brevis, it's just called opponens pollicis because it's the only muscle that can oppose the thumb. So the significant functional loss for motor function of the thumb is loss of opposition of the thumb. So that's what you would test for. You would test for opposition of the thumb, the ability to, let's say, squeeze a piece of paper between your thumb and index finger. That would require opposition of the thumb. Now, with long-term paralysis of the opponens, the patient may also develop something called ape hand, and we need to understand why that is, what that means and why that is. And it relates to a principle of muscle function that is called overriding of antagonists. And what that means is the following. When you have a joint that is crossed by multiple tendons of many different muscles, And those muscles have different functions. For example, you have a joint that's crossed by a flexor and an extensor and an abductor and an adductor, multiple different tendons crossing the joint. If you paralyze just one of those muscles, that joint will be held at rest in a position opposite the function of the muscle that you've paralyzed. In other words, if you paralyze a flexor, the joint will get pulled into extension. If you paralyze an extensor, the joint will get pulled into flexion. It'll get pulled in the direction opposite the function of the paralyzed muscle because you have unbalanced the joint and the antagonist will now override. So that means that if you have a long-term paralysis of the opponents, the thumb will get pulled into an unopposed position. Now recognize that at rest in a normal individual, the thumb is about 90 degrees offset from the other digits. Unlike the foot, where the big toe is in the same plane as the other digits, right? The hand, the thumb is 90 degrees off from the other digits. But if you have a long-term paralysis of the opponents, the thumb will get pulled into the unopposed position so that the thumb is in the same plane as the other digits, so that the thumb would be like the big toe in the same plane. And because there are many species of ape in which that's the normal hand with an unopposed thumb, that's why this is sometimes called ape hand, that a person with an unopposed thumb has a hand that looks like an ape. This is an indication of a median nerve injury because this is a chronic loss of the opponent's pollicis. Okay? So we have a flattening of the thenar eminence because you've knocked out all of those thenar muscles. The functional loss that you have is a loss of opposition, which can lead to an unopposed thumb. Now, the first two lumbricals are also going to be median nerve. We're going to hold off talking about those and what the implication of that is for a little while so that we can talk about all of the lumbricals instead of just talking about two of them. Okay? So that's what happens with the motor function when you have a median nerve injury at the wrist. Remember, the most important loss that the patient has is the sensory loss. The sensory loss on the palmar side of digits 1, 2, 3, and half of 4, because that's the important sensory distribution of the median nerve. Now, let's talk about a more proximal injury of the median nerve. You can injure the median nerve as it's crossing the elbow, Just before the median nerve reaches the elbow, it's crossing in front of the distal end of the humerus, the part of the humerus that's called the supracondylar region, just above the condyles, supracondylar region of the humerus. This is a somewhat common fracture site, particularly in younger people, resulting of falling on the outstretched hand. You can get a supracondylar fracture of the humerus. Because the median nerve crosses right in front of that fracture line, and because this is usually a displaced fracture, that can cause the median nerve to get stretched over that fracture site, causing stretch and trauma to the nerve, resulting in a median nerve injury. And because this is happening in the distal arm, now not only would the hand muscles be affected, but the forearm muscles would be affected as well. So now all of those anterior forearm muscles that are median nerve muscles are going to be affected. So now what that means is that all of the losses that we already talked about with a wrist level injury are still going to occur. We'll have the sensory loss, very important, on the 3.5 digits on the palmar side. We'll still have that. We'll still have the loss of opposition. You can still have ape hand if it's a chronic loss. You can still have the flattening of the thenar eminence if it's a chronic loss. Okay? But now there are some other things we're going to have. Firstly, we're now going to lose one of the major wrist flexors, but not both of them. Remember, the exceptions on the anterior forearm included the flexor carpi ulnaris. In other words, the wrist flexor on the ulnar side is not median nerve. That was an exception. That was ulnar nerve. But the flexor carpi radialis is a median nerve injury, is a median nerve innervated muscle. So if you injure the median nerve proximally, you will knock out the flexor carpi radialis, which means that when the patient wants to flex at the wrist, instead of being able to use both wrist flexes, they're only able to use the wrist flexor on the ulnar side. And so when they try to flex the wrist, the hand will be pulled in the ulnar direction, because that's the only side you're pulling on. So you'll get an ulnar deviation of the hand with flexion of the wrist. Ulnar deviation of the hand with flexion of the wrist. Okay? So that would be found if you have a proximal median nerve injury, but not if you have a distal median nerve injury. What else would be found? Well, much of the anterior compartment of the forearm contains the digital flexors. Flexor digitorum superficialis, with tendons going to digits 2, 3, 4, and 5. We have the flexor pollicis longus, with its tendon going to the thumb. And we have the flexor digitorum profundus going to digits 2, 3, 4, and 5. But remember, the flexor digitorum profundus is only half median nerve. The other half is ulnar nerve. So you're only going to lose the radial half of that, the part that's going to digits 2 and 3. So let's think about what that means. With regard to the thumb, we've already lost the flexor pollicis brevis because that's one of the thenar muscles. And now we're also losing the flexor pollicis longus. So now we've lost both flexors to the thumb, so you can't flex the thumb. You've lost flexion of digit 1. With regard to digits 2 and 3, the flexors for those two digits are the superficialis and the profundus. And both of them are median nerve. So now you can't flex digits 2 and 3. With regard to digits 4 and 5, one of the flexors is lost, the superficialis, but the profundus is not. Because remember, for the profundus going to digits 4 and 5, that's ulnar nerve. So you still have the profundus for digits 4 and 5, so you can flex digits 4 and 5. But you cannot flex digits 1, 2, and 3. So the patient has a loss of flexion of digits 1, 2, and 3, but can still flex 4 and 5, which means that if you ask that patient to make a fist, only digits 4 and 5 will get flexed. And that will result in a finding called the sign of benediction. So let me now pause for a second so I can show you what we're talking about. Okay, so here's my hand. Okay, so what we've said so far is when you have a distal median nerve injury at this level, in the carpal tunnel, which would be here, or a laceration here, you're going to lose the median nerve innervated muscles distal to that site, which would include all of the thenar muscles, right? So you'd have a flattening of the thenar eminence if it is a chronic injury, and you would have a loss of opposition. So the patient would not be able to do that opposition, okay? But remember, the patient can still flex the thumb because the flexor pollicis longus is still intact, and the patient can still abduct the thumb because the abductor pollicis longus is still intact, okay? We said that the patient would have a loss of sensation in the lateral 3.5 digits on the palmar side, right? Lateral 3.5 digits on the palmar side would retain sensation on the medial palm, okay? That's if it's a distal injury. If it's a proximal injury, we said that now the patient would also lose the flexor carpi radialis, so that a normal patient, when flexing the wrist, you wouldn't do it that way, you would do it this way, so you're working against gravity. When you're flexing the wrist, the patient is using both wrist flexors. But if a patient has a lesion that knocks out the flexor carpi radialis, then the patient would only be flexing on the ulnar side. So when they go to flex the wrist, instead of doing this, they would do this. They would have ulnar deviation upon flexion of the wrist because they're only pulling on the ulnar side. So you get ulnar deviation of the hand upon flexion of the wrist. So that would be true if you had a proximal injury of the median nerve here. It would not be true if you had a distal injury of the median nerve here. And then we said that because you've knocked out the flexipollicis longus, which is in the forearm, in addition to knocking out the flexipollicis brevis, you can't flex your thumb. And because you've knocked out all of the superficialis, but only half of the flexor digitorum profundus, that means you can't flex digit 2, you can't flex digit 3, but you can flex digits 4 and 5. So when the patient is asked to do this, what the patient does instead is this. Okay, the patient is trying to make a fist and does this instead. And that's called the sign of benediction. The sign of benediction. Okay, so sign of benediction is a finding consistent with a proximal median nerve injury. Remember, again, it would not happen with a distal median nerve injury because an injury here would not affect the forearm muscles. Okay? All right, let's go back to our slides. Okay, now let's talk about ulnar nerve injury. Ulnar nerve injury. So again, the ulnar nerve can get injured at 2 levels commonly, either at the wrist or at the elbow. So let's first talk about at the wrist. So the ulnar nerve, when it crosses the wrist, is crossing quite superficial on the palmar side because it's not in the carpal tunnel. It's superficial to the flexor retinaculum. It's not in the carpal tunnel. So it can be injured by direct blunt trauma on the heel, at the heel of the hand. Okay? So that's a way, or by a laceration, but that's less common. Okay? So blunt trauma on the heel of the hand can injure the ulnar nerve. So that, remember, the ulnar nerve innervates most of the muscles of the hand, which includes all of the interosseous muscles. And remember, the interosseous muscles are the muscles for abduction and adduction of the digits. And so with that ulnar nerve injury, you would have a loss of abduction and adduction of the digits. The hypothenar muscles, the muscles at the base of the little finger, would be lost. That's not clinically very important. You don't use those muscles very much. Lumbricals 3 and 4 would be affected. Those are the lumbricals going to digits 4 and 5. So now's a good time for us to talk about lumbricals. We'll talk about that in just a moment. You will have some sensory loss in the hand because remember the ulnar nerve does have a small sensory distribution, but again, not in a very important part of the hand. But now let's talk about the lumbricals. So remember there are 4 lumbricals called lumbricals 1, 2, 3, and 4, and they are going to digits 2, 3, 4, and 5. The lumbricals that go to digits 4 and 5 are innervated by the ulnar nerve. The lumbricals that go to digits 2 and 3 are innervated by the median nerve. So now what we need to do is think about what happens when the lumbricals get paralyzed, which means we have to know what the function of the lumbricals are. So let me show you. Let's go back to the video. Okay. So what lumbrical muscles do is what I'm doing right now. I am flexing at my metacarpophalangeal joint while simultaneously extending at my interphalangeal joint. Okay, that's the function of lumbricals. Flexion at the MP joint while simultaneously extending at the IP joint. If you flex all of them, you make a fist, you're not using your lumbricals. When you do this, you're using your lumbricals. So that means you could test lumbrical function by asking the patient to do that. That's certainly possible. But a more common way you might see this described in a patient would be based upon that same principle that we talked about a few minutes ago called the overriding of antagonists. Because after all, these joints, the digital joints, are joints that are being crossed by multiple tendons that pull in multiple directions. So if you knock out one of them, one of those muscles, the lumbrical, what will happen? We said the joint will get pulled into a position opposite the function of the paralyzed muscle. So if the lumbrical muscle flexes at the MP and extends at the IP, the opposite of that would be extension at the MP and flexion at the IP. Right? That's the opposite. And that looks like a claw. So that's called clawing of the digits. So clawing of the digits is an indication of paralysis of the lumbrical going to those digits. So that means if you have a median nerve injury, since the median nerve innervates the lumbricals going to digits 2 and 3, you would see clawing of digits 2 and 3. If you had an ulnar nerve injury, since the ulnar nerve innervates the muscles going to digits 4 and 5, then you would see a clawing of digits 4 and 5. So clawing of digits 4 and 5 means it's an ulnar nerve injury. Clawing of digits 2 and 3 means it's a median nerve injury. Okay? We'll come back to that point in a minute. Let's now just add on to this what happens if you have an ulnar nerve injury at the elbow. At the elbow. Now, the ulnar nerve, as we'll see, passes right behind the medial epicondyle at the elbow. That's the funny bone. And so because the nerve is quite superficial there, it's subject to trauma, medial epicondylar trauma. So if you knock out the ulnar nerve there, what's different between that versus knocking it out at the wrist? Well, the difference will be you will lose that major forearm muscle that it innervates, which is the flexor carpi ulnaris. So we've already said that if you knock out the flexor carpi radialis, when you ask the patient to flex the wrist, they will flex and get ulnar deviation, right? If you knock out the radialis, you'll get ulnar deviation. Well, now we can say if you knock out the flexor carpi ulnaris, you'll get radial deviation, right? Because now the patient is using only the flexor carpi radialis. So if when the patient flexes the wrist, if it deviates toward the radial side, it means you have a median nerve injury. I'm sorry, if it deviates toward, I said that wrong. If it deviates toward the radial side, it means you have an ulnar nerve injury. And if it deviates toward the ulnar side, it means you have a median nerve injury. Okay? So that's the additional finding you would find if you had a proximal ulnar nerve injury. Now, before we move on, I want to be sure that we distinguish between two different findings indicating two different nerve injuries. We said that if you have clawing of digits 4 and 5, like that, that means you have an ulnar nerve injury. We also said that if you have the sign of benediction, which you said was that means you have a high median nerve injury. So sign of benediction is a high median nerve injury. Clawing of digits 4 and 5 is an ulnar nerve injury. Now that looks like it could be confusing. And the difference between the two is not the very subtle difference between the hand looking like this and the hand looking like this. That's not the point. The point is that the sign of benediction is an active sign, whereas clawing is a passive sign. By that I mean this. The sign of benediction occurs when you ask the patient to do something. What you're asking the patient to do is make a fist. The patient wants to do this, and in attempting to do that, does that. If you don't ask the patient to do anything, you don't see the sign of benediction. But if you ask him to make a fist, then you'll see that. Clawing is not an active sign. Clawing is found at rest. The joint is being pulled by the overriding of antagonists. So if you look at the patient's hand at rest, the patient's hand looks like that. They're not trying to do that. They're not trying to do anything. But at rest, their digits are held like that because of the overriding of antagonists. So clawing is a passive sign, whereas the sign of benediction is an active sign. Okay? And remember again, clawing of digits 4 and 5 is an ulnar nerve injury. Sign of benediction is a high or proximal median nerve injury. Okay, let's go back to the slides. Okay, so we've talked about a distal ulnar nerve injury at the wrist, and we talked about the proximal ulnar nerve injury, and we said the additional findings would be the radial deviation upon wrist flexion. We're still going to have the loss of abduction and adduction because of the interossei. That'll be true for both. You'll have the loss of lumbricals for digits 4 and 5 leading to clawing. That's true for both. Okay, the sensory loss would be true for both. Now, here's a question. We said that a median nerve injury would give you clawing of digits 2 and 3, and we said an ulnar nerve injury would give you clawing of digits 4 and 5. What if the patient has clawing of all 4 digits? Where could you have a single nerve injury that would lead to clawing of all 4 digits? And the thing to remember is that even though 2 of the lumbricals are median nerve and 2 of the lumbricals are ulnar nerve, all of the lumbricals are innervated by C8 and T1. In fact, all hand muscles are innervated by C8 and T1. So if you had a C8 and T1 injury, you would knock out all of your hand muscles. And where can you have one injury to knock out C8 and T1? Right there. The lower trunk, the inferior trunk, is made up of C8 and T1. So you can have a lower trunk injury that would affect all of the hand muscles, including all of the lumbricals. So a lower trunk injury, which is a C8-T1 injury, would affect all of your intrinsic hand muscles, your thenar muscles, your hypothenar muscles, your lumbrical muscles, your interossei, all of them. You'll have some sensory loss in the C8 and T1 dermatomes. The way you injure the lower trunk, there are 2 common ways. One is by upward traction on the limb, pulling upward on the limb. And another way is by having what's called a thoracic outlet syndrome, resulting from the lower trunk getting compressed as it comes out of the thorax to go into the axilla as it passes over the upper rib, especially if you have an extra rib. If you have a cervical rib, that means the lower trunk has to go even higher to get out of the thorax. As it crosses over that rib, it can get compressed against it. So that would cause a C8-T1 injury. You can also, of course, have an upper trunk injury, which would be a C5 and C6 injury. Remember, C5 and C6 would be the very proximal muscles around the shoulder. So your intrinsic shoulder muscles, again, remember, they're innervated by a lot of different nerves. Some of them are innervated by the axillary, like this. Some of them are innervated by collateral nerves. These are collateral nerves. So a lot of different nerves, but they're all C5 and C6. And what these intrinsic shoulder muscles have in common, or what the proximal muscles around the shoulder have in common as their major, not their only, but their major function, is abduction and external rotation at the shoulder. Abduction and external rotation. So again, going to that principle of overriding of antagonists, if you knock out the abductors and external rotators, at rest the limb will be held in the opposite position, which would be adduction and internal rotation. So the limb at rest would be held adducted and internally rotated. In other words, instead the hand would be at the side, and instead of the palm of the hand facing your thigh, as it normally does, it would be facing back. And that position, with the hand at the side facing backward, looks like a waiter asking for a tip, so it's called a waiter tip sign. That's an indication of an upper trunk injury, or a C5, C6 injury. That's also sometimes called Erb's palsy, E-R-B'(S), Erb's palsy. The mechanism for injuring the upper trunk is, again, a traction injury, this time of the upper end of the neck, so forceful separation of the head from the shoulder. If the head gets pulled one way and the shoulder gets pulled the opposite way, you're stretching the upper trunk. So that can happen, let's say, from somebody who's riding on a motorcycle and gets thrown off the motorcycle and hits the ground with the head and shoulder hitting the ground. The head sort of separates from the shoulder, and you're stretching the upper trunk. And a fairly common way of getting an upper trunk injury is an obstetric injury, a birth injury, where if the baby's head presents in the birth canal, but the shoulders get stuck in the birth canal, if in manipulating the head, trying to get the shoulder free, if you manipulate the head too roughly and the shoulder doesn't pull free, there's a good chance that you're going to stretch or maybe even tear the upper trunk. And so it's not that uncommon to find newborn babies with these injuries who have the waiter tip sign.